Good afternoon. Before we get started, a few housekeeping items. Please utilize the chat box for any reasons, any questions you may have. We encourage attendees to interact and share comments or questions in the chat with our panelists as they are presenting. Please note that this webinar is being recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Take a moment to now carefully review this notice. Lastly, both the recording and slides will be shared in an email following the event. A survey will also be included. The members of the collaborative encourage you to share your feedback as we continue to plan future events. Welcome again to the Behavioral Health Integration Collaborative's Overcoming Obstacles series, Sustaining Behavioral Health Care in Your Practice. I'm Linda Paul, Senior Manager of Healthy Development at the American Academy of Pediatrics. I'm pleased to welcome you to our webinar in our Overcoming Obstacles series. The webinar series is a collaborative product of 8 of the nation's leading physician organizations dedicated to equipping physicians with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care in their practices during the current COVID-19 pandemic and beyond. Today's webinar, titled How to Address the Growing Behavioral Health Concerns Among Children, Adolescents, and Families, will highlight how physicians in practice have identified behavioral health needs within their pediatric patients and use behavioral health integration to provide comprehensive whole person care. At the end of today's session, we will have a question and answer time with our speakers where you can raise any related issues or concerns you may have or may be experiencing in your practice. Without further ado, I'm pleased to present our speakers for today. Today's moderator is Dr. Mark Borer. Dr. Borer is a child and adolescent psychiatrist as well as a general psychiatrist. He specializes in psychopharmacology, family therapy, and integrated care. His private practice, Psychiatric Access to Central Delaware, is in Dover, Delaware. Joining Dr. Borer, we have Drs. Tatiana Falcone and Christoph Diazio. Dr. Falcone is a child psychiatrist at Cleveland Clinic and assistant professor of psychiatry and neurology at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. For the past 13 years, she has been funded by the Health Resources and Services Administration and National Institute of Mental Health to improve the care of children with chronic medical illness, including implementing routine screening for psychiatric comorbidities in the Pediatric Epilepsy Unit and Outpatient Pediatric Epilepsy. She has also been working on improving access to children with special health care needs and improving the capacity of pediatricians to identify, evaluate, and treat mental health conditions. Dr. Diazio is a co-managing partner at Sandhills Pediatrics in North Carolina. He joined Sandhill Pediatrics in 2001, and he has helped lead the practice from an 8-clinician practice in 1 location to 3 locations with 28 clinicians. This includes 2 child psychiatrists, a PhD psychologist, 3 licensed professional counselors, and a Master of Education counselor who is a school liaison. Dr. Diazio is co-chair of the North Carolina Pediatric Council, which provides a forum for discussing pediatric issues with payers to improve quality of care. His professional interests lie in pediatric practice management. Thank you all for joining us today to discuss this important topic. And with that, I'll turn the discussion over to you, Dr. Borer.
Thank you very much, Linda. And I'd like to welcome everyone today and to this series. And I think one general theme for today to consider is that care for children is something that's so important. It was important before COVID-19, but it's even more important now. And so I'm really honored to be presenting with the other speakers, and we'll hear perspectives from child psychiatrists and pediatricians about integrated care, or about collaborative care and working together as teams. So I'm presenting first, and next slide, please. It's all about building relationships as we connect the networks of care, professional to professional, practice to practice, and organization to organization. So we have to build those relationships on all levels. Next. And COVID-19 has increased the need for access to care through collaborative care telemedicine, by behavioral health integration of child psychiatrists with primary care, by engaging our professional partners such as psychologists and nurse practitioners in mental health, and by embedding therapists in integrated practices where child psychiatrists can continue to collaborate not only with the primary care medical team, but the primary care mental health team. And that's really moving toward integration. Leadership teams at the hubs can consult on the most difficult patients, creating access for the spokes of care delivery out into the community and to community agencies as we add new opportunities for care delivery to the traditional practice of a child psychiatrist. Next. And it's propelled forward the need of not just telemedicine, but digital collaborative services. Many payers pay for direct care contact. They don't always pay for doctor-to-doctor contact or professional-to-professional contact. We're trying to change that as part of our work with access to care, because many children will be with their primary care practice for treatment, and they need the input of those of us in psychiatry and mental health. As we get toward more population-based care delivery, delivering the service fine-tuned to the needs of individual patients will be increasingly important. And for various increases in mental health issues below, we hope to deliver care through our local practices as well as through our work with regional and national companies. Next. So we continue to preserve traditional doctor-to-patient practice, but we like looking for new opportunities where we can be flexible and expand more consultative and collaborative practice as well. And that really shows our value and defines our role in collaborative systems, which are really an important component of our future profession. Next. So shown here, our future lies in collaboration, and you can take a quick peek at the primary care team and the mental health team. And if we're really successful over time, we're really joining these teams really around the same table, virtual or on site, through networks that address community health. Next. And shared leadership starts with a relationship between one mental health professional or team and a collaborative primary care practice. And leadership arises among various professionals on the team. And as I tell my colleagues, child psychiatrists, we will not be the leader of every team to which we consult, but we will bring leadership skills and be a leader on each team. Next. So ultimately, per Donald Berwick, changes in care at the patient and clinician level can produce better outcomes and lower costs. And that shows why that doctor-patient relationship is still going to be critical. Next. So some customized models for child psychiatry delivery. We have child psychiatry access programs in a number of states. We're going to be getting more with the federal money for grants. And also we're trying to adapt various collaborative care models, such as the University of Washington Ames Center collaborative care model to use with children. There are primary care behavioral models that still involve consulting with psychiatrists, and national or regional models where there's access to professionals by telemedicine. Next. So essential elements, we need competencies for collaborative work, both in training and in practice. Precision medicine, our academy worked hard on putting out measurement-based care in child and adolescent psychiatry in last year's fall clinics, and this year we're working on engaging our collaborative partners, and we'll have specific chapters in the clinics of North America this fall on engaging different professionals, psychologists, nurse practitioners, pharmacists, etc. So the team building, we try to move from exclusionary competition to resolving tensions through teamwork and shared leadership. Next. So for sustainability, we need collaboration and consultation service that are covered by payers, not just by grants. And that's always a challenge, and I think we'll hear a little more about that from Dr. Diazio. Next. I'm not going to read all these. I just wanted you to see for this slide and the next slide the various ways that we are trying to gain sustainability for our collaborative work, because one of the things that child psychiatrists will say is, who's going to pay us to come outside our office virtually or on site and do this work? And so these are some of the paths forward. Next. And also covering various codes as we transition from fee-for-service to CPT will be important. From CPT, I mean codes to value-based and population-based reimbursement. And ultimately, multi-stakeholder funding can really help with sustainability as we get into more community-level delivery. Next. So my last two slides, child psychiatrists, whether they perceive themselves as a collaborator within a practice or a consultant to a practice, are really engaging with the entire patient-centered integrated care team. And you see on that circle that it includes home-based care, community networks, and working with the payers as well. And finally, next. So we show leadership through expertise and flexible availability with our partners in medicine and mental health. Thank you. So next, I'd like to introduce, next slide, please. I'd like to introduce Tatiana Falcone, MD, and you've already heard what she does. She's going to tell us a lot more today about how her team has worked on integration and how it's saving the lives of children. Dr. Falcone?
Yeah, thank you. Yes, so I want to tell you our experience in the integration that we did with patients with chronic illness, and I'm going to focus today on the epilepsy team. Next. So as Dr. Burr was saying, a lot of the funding is coming just from the grants, but it should go more at the payer level too. But some of these studies were possible because of HRSA and the NIMH. Next. One, when we look at the different mortality causes, like we have seen, science has advanced in a lot of medicine, but one of the things that we still stuck in the progress is suicide prevention. So the rates that we were seeing before are actually getting worse compared to we had years ago. Next. So let me tell you a little bit why we focus our first effort in the kids with chronic illness with epilepsy. So in patients with epilepsy, we know that suicide is a preventable cause of death in patients with epilepsy. The mortality in people with epilepsy can be up to 3 to 5 times higher than in the general population. And suicide is one of the causes that why this is higher. And when they look at population-based studies, the mortality rates in this population can be 3 to 5 times higher. Next. So that's we believe that universal screening for mood and anxiety disorders in patients with chronic illness. Here I'm focusing on epilepsy, but we know this is also true for diabetes and for patients with other chronic illness, not only in youth, but also in adult. And in our clinic, we're currently offering this universal screening, not only when they're coming to see psychiatry, but when they're going to see the epileptologist or even also the pediatrician. So we think that screening is feasible and can save life. If we think how long it will take for someone to do a brief screening, can be as simple as asking one question, or if you do like a safety assessment, can do be 10 minutes and a full safety evaluation 30 minutes. And those patients who screen positive might need to be admitted to a hospital if they're not contacting for safety. So I'm going to focus on describing what was the model that we implemented here in our epilepsy center. Next. So I think something that is very important when we are managing patients with depression is to make sure that everybody leaves your office with hope. So when we're asking these questions and people are opening their feelings and telling us that they might be having suicidal thoughts, it's very important that they leave your office knowing that there are treatments and the treatments are effective. And there are a lot of things that they can do to help, like medication and therapy, and try to do psychoeducation for the family and the patient on how they can reach for help at the personal level, then also at the family level if they're seeing that their kid is getting worse, to reach out for help. At the provider level, if they're seeing their epileptologist or the primary care doctor, right? And they're having depression or suicidal thoughts, to make sure that they have all these resources. And I always ask the patients to download some of the apps that can help connect them right away with the help that they need. And if after a conversation we feel like the patient is still having acute suicidal thoughts, we might send them to the emergency room. Next. So when we look at some of the studies in kids with epilepsy, like the rates are high, not only in adolescents, but also in young adults. When we compare like the general population with the kids with epilepsy, some of the studies have reported, like in Dr. Kaplan, who did a study in a tertiary care center at UCLA, that 37% of the kids who came for like an outpatient PEDS epilepsy clinic reported having a suicidal thought with a plan in kids 5 to 16. Next. So in this slide, I wanted to sort of like show you a visual picture, like the red line. This is a meta-analysis of 29 studies in a lot of different countries. And when they look at this study, the red line in this study is the general population, and the blue line was the suicide attempts in the same population. So it's really high. And there was subsequent meta-analysis that also reported the same. Next. So when we think about the suicide rates in patients with epilepsy, so we know that a lot of these patients will have a treatable psychiatric diagnosis. Most of the times will be mood disorder, anxiety disorders, and we think that early recognition and early treatment is what is going to help us improve these, decrease these rates. Next. So we target this in two ways. In one way, we did a learning collaborative where we collaborated with 9 pediatric practices, some of them family health centers, some of them even here, part of the hospital, 55 pediatricians, nurses, nurse practitioners, social workers participated in this learning collaborative, where we were trying to improve the knowledge and the competencies in caring for patients with mental health issues. So we talk about depression, anxiety, starting a medication to help with this. We talk about screening and what were some of the things that can help with this. And to actually continue to support the pediatricians, what we implemented during this learning collaborative was that anyone in the learning collaborative who had an urgent question for a psychiatrist, like a consult, we have a consultation liaison team in the hospital. So we decided that because we wanted to improve this collaborative care, any one of these 9 practices who had an acute problem with one of the patients and wanted to discuss it, and the patient will definitely go back to PEDS, then we have this for like 1 year. And it was something that it was really helpful, and the pediatricians value this. And we child psychiatry too, because for us it's really hard sometimes when the patients, when we have like many appointments and the patients need to wait like more than 3 months, and we know it's an acute care issue. So having like the pediatricians do the first step, we felt it was very helpful. Next. So I want to tell you about the model that we implemented here. So anyone who was coming for like a pediatric epilepsy appointment receive PHQ-2. So if the PHQ-2 was positive, then they did a SDC, so 16 questions. So if the SDC was positive, then we did the ask. That's like 4 questions about suicide. So if the ask was positive, then the epileptologist during the appointment asked the question again to see if the patient was really having suicidal thoughts and they had a plan. If they say yes, then they either send the patient to emergency room or they contacted our social worker who evaluated the patient right there. So let's say the SDC was positive, but the patient is denying any suicidal thoughts. So we connected these patients to our child psychiatry service, and we also informed the pediatrician about it, and we created like a plan to sort of like follow these patients closely. Next. So we had like 400 patients who had like more than 5,000 encounters like in the last 3 years. So in 1 year, we were able to screen like from those patients, 400, 106 reported some suicidal thoughts. And so it was very similar between male and female. So from those 106, 13 patients were referred to the emergency room. And those patients, among 7 patients, there were also past history of 13 suicide attempts, something that we felt it was really interesting. Like 10 out of the 13 patients who had suicide attempt had both non-epileptic seizures and epilepsy. So 9 were female, 4 were male. They were anywhere from 9 to 18. And what we saw, the range was around like 1, and some patients, like half of the patients, not only reported suicidal thoughts, but also homicidal thoughts. Next. So 9 of these patients had been admitted to a psychiatry unit in the past. So we have a mean of like 2.6 admissions. And when we look at other screening, we found like anxiety was high. Like we know that if we do a screening for anxiety, the scale is one of the scales that we use. Having more than 25 is considered positive. The mean in this group was 47.6. And when we look at the further screening, the child depression inventory was high, 88.3 in these patients. We were looking at other issues that could potentially impact this. Trauma was, some of them reported some traumatic experiences. And we also saw high utilization of services. So those 13 patients had 41 visits to the emergency room in the last year with a mean of at least 3 visits. Next. So the message that I want to convey today is like, suicide screening can save life. In this case, it saved 13 lives. These patients did not, probably wouldn't report suicidal thoughts unless we asked them. So we thought that doing suicide screening and depression screening in the general clinic is feasible. And I think the development of the algorithm helped integrate it into a regular practice. Of course, we have to do a lot of like psychoeducation to all the providers, right? The epileptologists, the pediatricians, the social workers, and the nurse practitioners. And a lot of the people who reported suicidal thoughts, when we further questioned them, it was like passive suicidal thoughts, and some of them didn't need to be admitted to a hospital. So we feel like a screening for mental health in children with epilepsy is feasible and is also very important and necessary. Next. When we think about those patients with chronic illness, we have to think that epilepsy, is far more than just the seizure. So impacting like all the other comorbidities that these patients have, like the social withdrawal, the self-esteem, the physical inactivity, the school problems, is as important as controlling the seizures, because this will improve their quality of life, and this will decrease the probability that they'll become depressed and later suicidal. Next. So we feel like to be able to do this, it has to be like at universal level. So we screen everybody for like anxiety, depression, and suicide. And, we always try to make sure that the patient leaves with the thought that there's effective treatment, and treatment can be medication or therapy. And we try to communicate with the patients and the families that, when these symptoms progress, there's a risk for suicide, and it's important to understand why treating this can decrease the risk. And we follow everybody closely to make sure that after starting a new medication, they are getting better. Next. Thank you. Yes, so this was our experience in our child psychiatry clinic, and that is kind of like embedded in the epilepsy clinic at Cleveland Clinic.
Thank you very much, Dr. Falcone, for your presentation and all the facts and research. Two things that really stood out were, I loved your statement about giving hope to the people that you see, and that it's significant that you have saved lives already. And having that consultation liaison team available, not just immediately, but over the course of the following year, I think that's very reassuring for those working with children with these difficulties. Next, I'd like to have an introduction for Christophe Diazio, MD, FAAP, and he will be talking to us about a collaborative practice and from the perspective of a pediatrician working with various other professionals, and including mental health professionals, and also his practice's efforts at sustainability for these collaborative services. Dr. Diazio?
Hey, thanks so much for that nice introduction. I'm Christophe Diazio, and I'm ready for the next slide here. I am a general pediatrician in a small town in North Carolina. Our main office is right there in the center in Southern Pines, North Carolina. I want to give people a little orientation to where we are, and that we have two other practices, office locations in West End, otherwise known as Seven Lakes, and also over in Rayford, which is touching on basically the backside of Fayetteville there. Next slide. So to think about practice size, we're an independent practice, 24,000 active patients, over half Medicaid, 5% CHIP, the Children's Health Insurance Plan, and the rest private insurance, and a teeny tiny little fraction that's uninsured. Next slide, please. So how do we do this, right? I mean, this is sort of a crazy thing. How did we do this? How did we end up as a independent pediatric practice without a lot of reserves, ending up with basically 5 or 6 mental health clinicians? And the answer is some of it was the interest of our senior partner, who's been in practice for a number of years. And when this all started, he had been 31 years into practice and had developed an interest in mental health, basically because there was nobody else to do it in our community. So he became sort of the amateur child psychiatrist as a general pediatrician, did a bunch of continuing ed in mental health work, and really enjoyed it. So he had sort of built a practice accidentally because nobody else was doing it, and he enjoyed it. And so then one day we get this phone call out of the blue in October of 2013, and it's a child psychiatrist who says, "Hi, I'm moving to town for family reasons, and I'm triple board eligible in child and adolescent, adult psychiatry, and general pediatrics, and would you be interested in hiring me?" And we said, yes, you can have whatever you'd like. You can be fully employed, you can, we will help you set up a practice, but we know there are people in this community who desperately need your help. And so that was sort of how it all started. The traditional approach for a primary care practice integrating mental health is to get a social worker and sort of try that, or maybe a psychologist, or maybe a nurse practitioner. But we sort of flipped it upside down and started with a child psychiatrist. And she sort of became the lighthouse that attracted other people in town that were good mental health clinicians that shared patients and then were interested in working with her. So a lot of this was sort of accidental, that we sort of made the path by walking here. So first a psychiatric nurse practitioner came, and then a PhD psychologist, and then we've added 3 licensed professional counselors. And then sort of almost accidentally hired a master's of education who was a person who had worked as a school counselor for a number of years, and for some reasons needed to kind of get out of the school system, but still wanted to be involved in that care. And so put us in a neat position that so much of children's function is how they do at school. And so for us to have someone who had been on the inside of the school system, knew what was easy and hard for a school system, and could also sort of represent the mental health clinicians for what we thought they needed. So she does all our IPs, she helps with 504 plans. All these are things that kind of help us provide better functioning for those children. So next slide. So what are the barriers? Well, you know, I don't think I have that long. We're in a bizarre situation where I think anybody who even looks at this halfway knows that we don't have enough mental health care in America, and that we really need more. And so every community is different. Every community is going to look different. Every practice is different. So what you need in a certain environment may be totally different than what I need. If you're in the big city, you may have lots of people in the community to refer to and lots of access, and you just really need to work on making sure everyone talks together and is singing off the same sheet of music. Out here a little bit more in the country, we're sort of a little bit more where it's a long drive to go get care. And if we're going to try to do actual therapy and things like that rather than driving back and forth, and again, all this started before the pandemic and actual coverage for telehealth, right? It just made sense to do that in the office. So as I mentioned, over half of our patients are Medicaid. And so in North Carolina, we had this sort of unusual bespoke little thing where we had separate insurance companies that were designed just for Medicaid, and they handle all the mental health claims. And so they had a closed panel. And so initially when we called them up and said we had a child psychiatrist, they said, well, we're full, we don't need anybody else, which, you know, caused a lot of laughs, and you know, we found that pretty funny. So the point is, we had to push. We had to go to the CEO of that company to say, we know you're not meeting demand. We know you don't have enough child psychiatrists, and yes, we really do need this person to work here. So once we did that, we were able to get going, and those conversations then led into other discussions that led to us having going to the LME and saying, we have this many patients, we want to provide great care. The CPT-based payment system doesn't enable great care. So can you give us a grant essentially to provide for good care? I don't think it's a big surprise in America that we have not a whole lot of therapy and more medicine use when there's not a lot of payment for therapy. So trying to provide what we thought was the best care, a combination of medicine and therapy, by having some additional financial supports. And then there's like silly stuff that you'd never think of. Like we started to get every claim required a manual review. Well, once we actually penetrated the maze that is health insurance in America, we found out the reason that we were getting audits were because our group NPI was single specialty general pediatrics, right? Rather than a multi-specialty NPI. And that was basically all it took to take some of the claim edits to stop flagging all the claims coming from Sandals Pediatrics for mental health care and psychological testing and therapy. Next slide, please. So we tried to turn problems into opportunities. So the LME, that sounds really terrible, right? Oh my gosh, you're over half Medicaid. How could you possibly do something like this? Well, that was actually the opportunity, because in many respects, Medicaid, at least in our state, was more interested in helping children with mental health than some of the private insurers were. It's always easy to beat up on insurance companies, but you know, they long for the day that Americans will like them as much as they like used car salesmen. But the challenge that the private insurance companies have is just because you have a Blue Cross card or United Healthcare insurance card in your wallet, that doesn't mean that the mental health payment is paid for by that version of Blue Cross or United Healthcare. Certain employers can then choose to send the mental health benefit elsewhere. So some of these private insurance companies are limited because they're not really sure how many of your patients they're paying the mental health claims for. So there's a lot of challenges in making that work. So we took this problem that, oh my gosh, it's all Medicaid, and turned it into an opportunity. We had meetings with our LME, or local management entity, which, like I said, was the North Carolina Medicaid entity that handles only the mental health claims. Those meetings led to better outcomes, where a few of our patients were spending times, you know, handcuffed to the, to the bed in the emergency department, waiting for an inpatient facility to open up, because we were able to intervene in that child's care and provide therapy before they got to that point of crisis where they needed inpatient care. That then led to us getting off altitude, that we've had visits by the state Medicaid director, who is very interested in what we're doing. The Secretary of Health and Human Services for North Carolina came to visit us to see what we were doing here, because we feel like there's a big advantage in having that full integration in a primary care medical home, where just like we take care of your strep throat, we take care of your brain too. We continue to work on efforts with private payers. You know, it's a frustration. Anytime you want to get an extra nickel in primary care, you need a 20-year study. But I do think more and more people are realizing the value of integration and are getting closer to be willing to pay for it. We also have challenges in North Carolina that starting July 1st, our current straight Medicaid system, where there's one Medicaid system for the whole state, is switching to what most states in America have, which is where private insurance company manage the Medicaid patients. And so can we get these privately insured Medicaid companies to be willing to support our mental health program? We continue to have these conversations. We continue to work on it. So the point is, none of this is easy. We don't have it all figured out, but the point is that we're continuing to try and work through these barriers as they come up. Next slide. So, you know, in conclusion, I'll just say this isn't easy, but it sure is worth it. And once you try this and you have integrated mental health, nobody wants to go back to a silo. You know, as a pediatrician, you know, we thought about it as, oh my gosh, you know, wouldn't it be so great to have integrated mental health and be able to help them? And that'd be so great for us, and so great for us, and so great for us. And, you know, I mean, I have a kid who comes in with suicidal stuff, and I run to see my mental health folks, and I'm, you know, very worried and scared and worried for the family. And, you know, they kind of are, you know, this is like their ear infection, right? They're not all that excited about, like, yeah, okay, well, we'll do this and we'll do this, and it's not a big deal. And then on the other hand, one of their patients, you know, comes in after punching a hole in the wall, and do we need an X-ray? And I'm like, oh, you know, maybe boxer's fracture, it's an X-ray, that's easy. So the point is that there are also benefits for integration for the mental health team, that for those clinicians, they are treated, I would say, savagely by the insurance industry in America. And a lot of medical practices have built out big, heavy billing departments that can go fight for payment. So it's helpful to them too. And then basic business functions that we do in primary care, you know, is a big support to those folks. So I'll just kind of wrap up and say it'll take a sustained effort, but it sure is worth it. And I'm happy to answer anybody's questions. Dr. Borer?
Thank you, Dr. D'Azio. That was really an inspiring presentation, because like Dr. Falcone's presentation offered hope for patients, your presentation offers hope for patients as well. It also offers hope for professionals like child psychiatrists. And I think what you showed is that you started with one person approaching your practice, one professional, and that gives hope for those practitioners, and we have many in child psychiatry that are in small practices. It gives hope that they could take part of their practice or all of their practice and transform it into a more collaborative, sustainable type of practice. So thanks for your efforts, and thanks for the efforts at sustainability. I'm going to take a look now at questions, and I'll see if and while we're looking for those, I just wanted to go ahead and just ask each of you again, very briefly, how the pandemic itself changed your practice, or how you had to alter your practice, transform your practice, or enhance your practice in order to meet the needs of the kids during COVID-19. Could you start, Dr. Diazio?
Sure. Yeah. I mean, for us, it was crazy. If you're doing therapy and you're in a small room with someone, and we weren't sure about the infectiousness of COVID at the time, boy, that seemed like a terrible idea. North Carolina, both private and Medicaid, moved very quickly to cover telehealth. So we spun up a telehealth portal, basically immediately flipped everything to telehealth, hung Wi-Fi access points in the parking lot so our folks with crummy Wi-Fi could drive up and connect our office network. I'm not sure anybody actually did that, but we did it anyways. And so just rolled into telehealth aggressively and quickly. And we're just now, like just in the last 2 weeks, with vaccines being far enough post-vaccines for our mental health team, are bringing some of them back into the office. But it has made a major and sustained shift to telehealth. You've got your anxious adolescent, and you can do a telehealth visit from them from their bedroom, and you can see, the posters on the wall about the music they like. There are things that are a richer experience about this, right? So I would say the biggest thing is telehealth, and just that, we've had FaceTime for 15 years. The only thing that changed was the insurance companies agreed to pay for it.
Thanks.
Yes.
Dr. Falcone, would you have a response also from your perspective of how your clinics had to change to adapt to COVID-19 and how you managed to do that?
Yeah, so even the year before of COVID-19, part of our impact grant with HRSA was implementing telehealth. So we were working with the pediatricians and the epileptologists and the whole Neurologic Institute to try to increase. And we had, before COVID, like a 30% of the providers kind of like interested in telehealth. And of course, after COVID, it went to like 100%, right? And we went from like 200 visits a month to like 5,000. So it went viral, yes.
Thank you. I have a question from the chat for Dr. Diazio. And it is, insurance reimbursement is typically way below that which a therapist receives from cash paying patients. What incentive do mental health professionals have to join your practice versus staying independent in their offices?
I mean, I think, part of it is, again, that we're a big, heavy practice with a big, heavy HR thing. So, we have a top flight health insurance plan. We have, 401k, we have all those kind of standard things. So we have probably better benefits than an individual therapist would have access to. And then quite frankly, we move money around. We've negotiated aggressively for better payments from the plans. And we feel that we like to pay our mental health staff a fair wage that makes work fun for them. And we've also tried to strip some of the hassle out. Like one of our child psychiatrists talks with some of their friends who can't believe she doesn't have to do any of the prior authorization work, that our staff takes care of that, or that when we're doing clozaril and they have to jump through all the hoops, that our nursing staff jumps every hoop they can without sort of wasting the doctor's time. So I think it's not just straight up the finances, it's the other. Now, if you have a cash pay practice, you're totally healthy. The presentation of this model, what we're doing here, isn't to say everybody has to do it, but as far as what's in it for them, we try to make sure it's a fair payment for important work, and that it's a fun place to practice medicine.
Thank you. I found in my own practice and in my own state that a lot of what we have to do as child psychiatrists and pediatricians, we work together, is to advocate and to educate. We're advocating with our insurance commissioner, with our legislators. We're educating everyone we can about the importance of funding collaborative care and extending telemedicine into the future so that it can be available to anyone anytime, depending on the needs of the child and family. How do you see, I'll ask this to you also, Dr. Diazio, how do you see the use of telemedicine going forward? Do you think that's here to stay, and why so?
I think too many insurance company executive children have been treated via telemedicine for me to think that it's really going to go away. I think it's too easy. You know, the venture capitalists funded all those private companies who went running into the space, you know, basically burning cash. But, you know, what I see as the light side of telehealth is as when it's an extension of the primary medical home, it's an extension of someone's relationship rather than 1-800 generic widget doc, you know, which is how some folks have telemedicine.
Thanks. And Dr. Falcone, I know you had mentioned telemedicine as well in your comments and your program. Do you see telemedicine being important in the future of your program?
Yes, we see that telemedicine is here to stay. And as we recognize that there are some patients that will still need the inpatient visits, I think, as Dr. Diazio was saying, you're getting so much more information just from seeing like the house and like some of the family interactions and the kid more relaxed on their own environment, that I think we're gaining a lot for having some of the visits being telemedicine.
Thank you.
Sure. I mean, you do this deep breathing exercises with the anxious kid at home on their own bed. That's just, you know, our therapists are like, this is just a different experience. This is kind of cool.
Yeah. Also, Dr. Falcone, what would you tell other practices who would like to do more screening but may fear having insufficient places to refer people to? Like, if I screen for depression and I find it, what am I going to do with these kids? What would you tell them to go ahead and do?
I will say that is so important because like patients are not going to say, right, that they are having these thoughts unless you ask them. And is like, as long as you prepare the physicians, like the pediatricians, the specialists, right, to understand and know how to do screening, it can really, like, after we did this learning collaborative with all the pediatricians and review like the scales that we were using and how we consider this scale positive, right? And like, of course, we have all the questions, like, but we only have, like, for epilepsy, we had one psychiatrist for child and one psychiatrist for adult. And they were like, you know, 2,000 patients in the child section, and I don't know how many in the adult. But we have like all the epileptologists who were at the beginning really worry about implementing this. And the more that we did this and the more that we all work together collaboratively, we realized that, you know, the full effect that we can have is so much bigger, right? Because it's impossible for me to see all the 2,000 people, but if we are all asking the questions and we kind of are triaging the questions to the right person at the right moment, we can do it. So like later, I went to do grand rounds for like the pediatric neurology side, right? And the epileptologists were the ones advocating to do the screening, right? For like all the other kids with headaches. And because after the implementation, they realized that is feasible and it can really improve their quality of lives. And like, of course, we were there to support them, right? Let's say that the pediatrician or the epileptologist started the medication and the kid was not doing better. We collaborated with them and saw the patient for, you know, 1, 2, 3 times. And then it went back to the pediatricians and we were like in the back. If you need help, you can call us. But we want the patient to go back to their medical home. Yes.
Yeah, I mean, I think that just to pick up on something Dr. Falcone said, I mean, it's a real force multiplier effect. Like, you know, when I trained in pediatrics, even just 20 years ago, I mean, there was sort of a bright line, like, you know, you don't prescribe antidepressants, like maybe you do a little bit of Adderall, but you don't go any further than that. And having access to child psychiatry makes you more comfortable and more willing to start doing a broader practice, because if you try something and it doesn't work, and let's say I know one trick like for how I treat depression or anxiety, but having additional people to go to who will help me makes you more comfortable. To your, you know, the question of how do you do screening, I think knowing that you have some backups is just really helpful, I think, from a primary care doc standpoint about what gets you comfortable starting. And I think that looks different in every state. The Child Access, you know, Phone a Friend program is a wonderful program that I think a lot of states have rolled out.
Thank you. In our state, we have set up a child psychiatry access program, you know, after the Massachusetts model, and about half the states now have those. And that money I mentioned in the beginning that is coming, and this is in response to a question in the chat about any grants that would support starting a program. There will be, if you already have a child psychiatry access program in your state, you may be able to sign on and work with them. If you don't have one, that money is coming, and it helps to have a sponsor within your state. In our state, it was our child mental health division that actually took over the sponsorship and is running the grant. And it's a way to get money to institute more collaborative care between, for instance, child psychiatrists and the primary care teams, including their embedded psychologists and social workers. So it really gets an increase in access to care. And I'd highly recommend that as one approach. The other thing is, once you have contact with pediatricians, what I found is if they get to know you and they know what you can do to help, they tend to want more time. And it's opened up opportunities for us to spend more time in pediatric practices. And that's going to really prepare them for, again, population-based payment, value-based payments, capitated payments, where they need to be providing coverage for the whole shebang, the mental health, the medical health, and you know, the healthcare, the social determinants of healthcare. So I had another question. I'm looking for any that come into the chat. I had an additional quick question, and that is, can you speak a little bit, Dr. Diazio, about the billing of the practice? Do you actually do your own billing to various places, or do you use a billing company? How do you manage to collect for the services that are covered?
Right. I mean, we do all our own billing. It's all in-house. We've had to learn a lot about mental health billing and what the rules are, how it all works. But yeah, fundamentally, at the end of the day, it's the CPT code going out the door, whether it's for a vaccine or whether it's for psychotherapy. And then does that get paid? How does it come back? What hoops do they want you to jump through? Do they want you to do prior approval? You know, all this kind of silliness. You know, but yeah, I mean, it's not conceptually that different from just a regular office visit.
Thanks. Well, I want to thank both of you. And again, it's been an honor, you know, hearing your presentations and being able to chat with you. And I'd like to reintroduce Dr. Linda Paul to finish up.
Thank you, Dr. Borer. Well, time has flown by and we're at the end of our time today. Before adjourning, we ask for your valuable feedback in our short survey. It can be found in the Zoom chat box and will also be sent to you via email, along with a link to this webinar recording and the slide deck. Your feedback is greatly appreciated and will help inform future educational sessions and resource development by the Behavioral Integration Collaborative. Our next webinar will take place on Thursday, June 24th at 1 p.m. Central Time, and will address how implementing behavioral health integration can help increase joy and satisfaction in practice. Stay tuned for more details. We also hope that you'll visit the main Overcoming Obstacle Series webpage on the AMA website and the playlist on the AMA's YouTube channel to access all the previous webinars in this series. And check out the collaborative's resource, the BHI Compendium, which provides a helpful framework for how you can make BHI effective in your own practice. Starting today, the AMA will be also hosting an online discussion on what's next for behavioral health solutions on the Physician Innovation Network platform. AMA will also be hosting an interactive discussion on using telehealth to deliver integrated mental health and behavioral health care in practice settings. And we had some discussion on that today. Check out the Physician Innovation Network and the AMA Telehealth Immersion Program linked in the chat and on the AMA website for more details. Thank you so much again to today's speakers and to all of you for joining us. Have a great rest of your day.